Fuston has been with the Washington-Baltimore HITDA, which is a high-intensity drug trafficking area, for 16 years. Since 2005, he has served as the program manager of the Investigative Support Center at HITDA, providing mission-critical intelligence for federal, state, and local law enforcement through the use of innovative techniques to produce tactical, operational, and strategic intelligence products with a focus on results. Mr. Fuston earned a BA in psychology and a BA in communication from Salisbury University and an MS in human resource management from Towson University. He has also taught graduate and undergraduate courses in intelligence at Mercyhurst University.
Great, thank you.
Thank you.
Good morning.
Good morning.
How's everybody? Good? All right, it's good. I always try to gauge the crowd, whether you're going to talk back or it's just going to be that cloud, you just look at me. You're kind of like half in the middle, so that's fine. So what did the bio mean? Really what it boils down to is I am a data geek, or data weenie, or whatever else you want to call me. I'm not smart enough to be a researcher, I'm not brave enough to be on the front lines like any of you, so I use data to help make decisions, is what we try to do. My goal, my theory, our theory at Washington-Baltimore HITDA is that we can collect data, we can organize that data in such a way that we can provide proactive results to anybody in this room to save lives. That's our goal. We can do that for law enforcement, we can do that for treatment, we can do it for public safety, we can do it for whomever comes to us and wants to share data with us, and we will make sure that we comply with our sharing MOUs and laws to make sure the data is not shared where it's not supposed to be shared, but still to come up with results. And I hope that I can show you some of the ways that we're doing that now. The problem that we ran into is, and I'm sure anybody in this room has run into this, right? A problem occurs, and what does the boss want to know, or the decision maker? Everything you know about the problem, right? They don't get very specific, they just, I want to know everything. Tell me everything right now. So we need to know that everything about that threat. We want to be actionable, we want to give data back, we want to give something back to these decision makers that allow them to do something with that information. Make some decision. Are they going to provide treatment here? Are they going to make an enforcement action here, or other action they can take? And then finally, one of our goals is to be proactive, especially with this heroin opiate problem. The problem that we're defining is people are dying, and we want to engage with them prior to that event so that we can stop them from dying. I think we have some ways we can do that. First, let me talk about the HITDA. Is anybody familiar with the HITDA? Or HITDA, as some people like to refer to it as? Was a high-intensity drug trafficking area, and it's a federal grant program. So the reason I mention this is a lot of people, or some people, will look at HITDA as a law enforcement entity, and we absolutely are not a law enforcement entity. We are treatment, we are prevention, we are law enforcement as well, but our real goal is to increase the effectiveness and the efficiency of anybody, our initiatives, which are treatment, prevention, law enforcement, within Maryland, DC, Virginia, and West Virginia. That's my goal at Washington-Baltimore, our goal at Washington-Baltimore HITDA. There's 28 HITDAs across the country, and we all have similar goals. We're also focused at the law enforcement side on the drug trafficking problem. We are up at the top of that food chain. We're supporting people like Group Supervisor Hendrick, I had to call you that, but to help provide data at that level. We also want to provide this actionable information, though, to everybody. We work a lot with Anne Arundel County. We're working with the police department, we're working with the public health, we're working with the health department. Thank you, Dr. Jen. We're working with whoever we can to help provide some actionable information. So let me talk about the traditional process, and I see that it's completely washed out, no one can see what this is. But from the intel weenie side of the process for me, the process is very linear often. First, you come up with a requirement, which means someone comes to you and asks you a question. What is the problem? Why is heroin a problem for our county? And then you move forward and you collect data that's specific to that, then you analyze the data, and then you give a result. At the HITDA, what we're trying to be is much more proactive. We are trying to collect data on an ongoing basis that is relevant to this threat so that we can provide you with actionable information from the very beginning. We want to collect data, any data, that is relevant to opiates in Anne Arundel County, in the state, in Virginia, in DC, in West Virginia. Any piece of data that we can get our hands on we would like to have that data so we can provide, again, resources back to you. Some of the examples of this data that we've looked at. Fatal overdose data, non-fatal overdose data, communication of data, debriefs, drug samples, case data, parole prevention data, arrest data, gang information, treatment data when we can get to it. Any piece of data that we can collect and then talk with you, provide a feedback to you on something actionable. Most of the time, what we're able to provide back is down to the person level. This person needs help. And what that help is up to whoever provided us that data. If we're working with a law enforcement agency and we're working with their data, it's going to go back to that law enforcement agency to decide what they want to do with it. And in Anne Arundel County, I think we have a great relationship between the disciplines, and they're able to share this data. If we get data from public health, it's going to be up to public health to decide what they do with that information that we go back. But we are down to the person level. We think we can identify the people that need your help. In order to do that, though, we have to share data. And this is a huge mountain that some of us need to overcome. We know that. We know there's a challenge with data collection. We're very aware of HITDA. We're very aware of privacy rights. But we need to find ways in order to allow this to happen. And we can do that while protecting the data. I go back and I remind you, the HITDA is a grant program. We are not an entity. We're not law enforcement. We're not treatment. We're not prevention. We're a coalition of all of that. We can get that data. We can protect your data. We can analyze that data, and we can give that data back to you directly. What are we giving back? We're giving back things like this. Does this make much sense? I hope so. The circles with the red around them, that would be an individual. That is a person that we know has overdosed on heroin, either fatally or non-fatally. We know they have overdosed on heroin. All of the yellow dots are communications that we're aware of or interactions between those people that have overdosed on heroin. We know that is a group of 5 people that have overdosed on heroin, and they have some commonality. They've called each other, they've met at a location, they live together. Whatever, they have some commonality between them. We think by identifying those individuals, we can identify these organizations, and we've done this. This is, I keep saying we think. We've done pilot programs, and we've done this. We've shown that we can collate people together. We can identify the connections between people, and then give that back proactively to public health, public safety. We look at it like this. We have 2 agencies' data, you got a lot of data, right? If you look at anybody in this room from a law enforcement or public health, you've heard the stats that we're looking at. There is a lot of people that need our help. A lot. And we need to find out who needs our help now. We need to decide today who needs our help right at this second. We believe by taking that data, bringing it together, we can identify the subset of people that need your help the most right now. And we've done this. We've shown this data collaboration. We've shown the results coming to you. We will give this data back to you while we're protecting it. Other trends that we've seen, we can provide other avenues of research or other avenues of action through watching movements and data. I won't go through this. Group Supervisor Hendrick talked about some of this as well, but we can see that we have people that are coming to this county to get their drugs. They're coming to Anne Arundel County from other places, Pennsylvania, West Virginia, Ohio. We're seeing them come here to get drugs at times. We can see these trends and patterns, and we can also work with our other HITDAs or other resources in Virginia, West Virginia, in DC, and then our other HITDAs across the country to share data with your permission and with your request. Any questions for me? Yes, ma'am.
Hi, good morning. Just in watching your PowerPoints, I saw prevention, treatment, law enforcement, where you collect data from any of them. What I did not see is the recovering community. Do you have a viable means to collect data about the recovering community? Because while I don't. I don't like those. I'm sorry. They intimidate me as crazy as it may sound, and my voice will carry. Thank you, though. While I heard the number of 24 million Americans in this country who are in active addiction, there are also almost an equal number of about 23.5 million Americans who are in recovery.
Right.
Admittedly, anonymity can get in the way there, but do you have a viable means to track people in recovery?
I don't have any data from people in recovery, but I hope the message that I can give you is I can take any data that you can help me get access to, and I can produce measurable results with that data. With any data. And I think that it comes down to figuring out how can we do that while protecting privacy rights.
Okay, thank you.
Similar kind of piggybacking question. I mean, I think we've heard this morning from
Everybody's afraid of the mic now. They're not one of those electrocuting things, you know?
Okay, so good morning and thank you for your presentation. I think a piggybacking question is we've heard that 3 out of 4 new addictions do begin with prescriptions or misuse of prescriptions. Something in terms of the prevention side that we would love to identify is working with primary care providers, whether that's through education, training, but to be able to find training, screening, some sort of regulation, but to be able to identify those providers who may be over-prescribing, connect with these networks of folks who are overdosing or who have historically visited them, and obviously HIPAA presents challenges. So I was wondering if you could speak to from your perspective, some of the challenges of engaging with a primary care network, with a hospital network, to see from the medical side where some of those addictions might be starting.
Sure. So we've seen, I just left there was a national conference last week in Atlanta on RX abuse, great conference, and I saw a lot of examples of proactive analysis to that point. Let's identify these prescribers ahead of time and talk to them. Maybe they're not even aware that they're overprescribing. They just need to know, hey, did you know you prescribed this drug to this person and then that same individual went to 5 other places and got it? Or did you know that this individual, you prescribed this drug and we didn't find any of that drug in their system at the time of the death? There's these interesting statistics. And that's a lot of analysis with the prescription drug monitoring programs from these states. In Maryland, we do not have access to go into that data and exploit that data. And I think that that's a challenge for us. What was the firm that you used? Law Enforcement Challenge, I think. I'm going to borrow Mr. Hendricks' quote. Could we do that? 100%. Have we shown valuable results from that? 100%. We've also seen, and we're making paths to get into drug testing information as well. Can we look at drug testing data and find trends within that data to identify these problems before they exist? There was an example out in California where they were using, I don't necessarily like the name, but they called it the death card. And they were looking at drug test results, prescription drug monitoring results, law enforcement results, and medical examiner results. And they could show the whole profile of these individuals. And they could show the problem in the beginning. So I think the answer to your question is yes, it's data. We've got to get to this data. We have to find a way. Every time, the other answer to your question is every time I approach a hospital, they say, HITDA, what's that? And we have a challenge there to get to that data. We have the data to answer the question. We just need to find a way to get that data into one spot.
I have the microphone next. Thank you so much, Mr. Houston, for coming and talking. I really appreciate it. And the other presentations that I've heard you at, really excellent information. And I know that we'll be meeting later on this month to discuss exactly what you're talking about. And I'm hoping that with that discussion will come some ability for us to be able to share data to try to get a little bit at what you're talking about with the prescription drug side. But I'm also interested in seeing how we can better collaborate with our hospitals and other providers to identify, and law enforcement and fire, EMS, who are well represented here today, to try to identify those who have experienced especially non-fatal overdose to try to intervene. My question, I guess, it's a little bit similar to the previous person's, is do you have examples of how that collaboration has worked in other parts of the country? Because there are HITDAs, as you mentioned, elsewhere.
We do. We do have examples. Matter of fact, from that conference I went to last week, I requested them to send me that data so that I can share that at our meeting next week. so we're going to do that. We also have examples here in specific to Anne Arundel County, not necessarily with that data, but the police department here, the state's attorney's office here, the health department here have been very proactive. We have examples of us identifying individuals before they die. They've overdosed 3, 4, 5 times within 10-day spans. We've identified those people. We can show those people. We can give that information to whoever is relevant. We have examples from this county.
Just quick, and I might have missed it because I'm a senior citizen, but isn't there supposed to be something new now that the doctors, going back to the prescription drugs, have to put that information into a system where it can be utilized by other doctors to see if someone is going in on a repeated basis? And I don't know if you are a part of that, but do you know what's involved if a doctor doesn't do that, or how does that take place, and is it a requirement now for the state of Maryland?
I am not an expert, but unless someone wants to stand up and answer it, to my understanding, yes, the prescription drug monitoring program is in existence in the state of Maryland. I believe it's voluntary.
Sorry. Just to piggyback on his response as well. So it's still a relatively new program. So there's, as I understand it from the state, the infrastructure is also, I mean, I'm talking about the technical, the computer network part of it is not as robust as it could be or should be. There was a bill that did not get out of committee this past General Assembly, which would have mandated that providers, and not just prescribers, so nurse practitioners, physicians, etc., but also pharmacists, that they check the PDMP in Maryland prior to prescribing or dispensing. And I think that there was a concern from just the folks who were managing the system that that would overwhelm the system very quickly, and so there'd be delays. And clearly, there's a balance that has to be struck when you are a provider, pharmacist or physician or nurse practitioner, that you don't want to delay care unnecessarily. You don't want to have people wait around for hours and hours to get their prescription if they're there for an hour. But so there's a balance there. But I think the move is towards that in the state of Maryland. But it is still a relatively new system. It just came out or went live maybe 12, 15 months ago.
Thank you.
Any other questions? Well, thank you very much. I challenge you to reach out. This is my contact information. Is there any data that you want us to analyze just with your data? I'd be happy to do that. And if you want us to analyze your data with another data set, let's have a big group meeting. Anything I can do to help, that's what the HITDA is here for. We're a resource to everybody in this room. Thank you.